Welcome to the Rad Onc Smart Review Head and Neck Cancer Series.
Today, we're going to tackle, what is arguably one of the most complex decision-making points in head and neck radiation oncology,
I think so.
the management of unknown primary squamous cell carcinoma. It's that scenario that residents, well, everyone really, kind of dreads.
Yeah, the classic neck mass without a mucosal home.
Exactly.
And what makes this so critical for board preparation, and for safe practice too, is that you're forced to build your treatment strategy entirely in reverse.
Right. Normally, the primary tumor, that's your map. It tells you where the at-risk drainage basins are.
But here, you don't have that map. You have definitive proof of metastatic disease in the neck, SCC, and a lymph node, but that's it.
So the whole exercise becomes this rigorous, risk-adapted calculation. Do you go with a large, comprehensive field or something more focused and selective?
And that decision is driven almost entirely by the nodal geography, and I think now more than ever by the molecular biology.
It is. We absolutely have to learn how to use these biologic clues to sort of stand in for the missing anatomy. That's really the core of modern unknown primary management.
Okay, so let's unpack this with a standard, a really high-yield board anchor case. This is the kind of scenario you absolutely have to be ready for.
Okay.
So imagine you're reviewing the case of a 55-year-old male. He's got a smoking history, maybe 10 pack years, but he quit 5 years ago. He comes in with a right-sided neck mass he just noticed a couple of months ago.
Classic presentation. Total board setup. So what does the workup look like when it finally lands on your desk?
The workup is stated as being rigorous and complete. So physical exam, flexible scope, all totally normal.
Okay.
Then you get a contrast CT of the neck followed by a whole body PET CT. And it shows a solitary, well-defined 3-centimeter FDG avid lymph node.
Where is it?
It's located centrally in the right level 2A basin. And crucially, the report says no other suspicious FDG uptake anywhere else. Not in the mucosa, not the chest, no mets.
So we're looking at a, N2A by 8th edition staging, a 3-centimeter node right in that primary drainage pathway.
Exactly. So tissue diagnosis was obtained. FNA confirms metastatic SCC. And now for the really key molecular findings. The biomarkers come back P16 positive and EBV negative.
Okay, that's a huge piece of the puzzle right there.
It is. And the surgical staging is really where this diagnosis of unknown primary is earned.
Yeah.
The patient underwent a full pan endoscopy, directed biopsies of high-risk spots like the vallecula and piriform, plus a definitive right palatine tonsillectomy and adequate tongue-based sampling. All of that mucosal pathology came back negative for a primary.
Wow. Okay, so that is a truly exhaustive negative workup. So the consult question coming to you, the radiation oncologist, is pretty straightforward.
Yeah, we can't find the primary. What do we radiate? So let's just simplify that opening statement. If you're a resident, you're in the hot seat, faced with this exact scenario on your oral boards. How do you verbalize the diagnosis and your initial management rationale? You need a quick, confident, 3-second answer.
This is a patient with mytene-16 positive squamous cell carcinoma metastatic to a right level 2A cervical lymph node, consistent with head and neck unknown primary after a comprehensive diagnostic evaluation. I have verified the workup, including definitive tonsillectomy and tongue-based sampling. Given the HPV-associated biology, the occult primary is presumed to be oropharyngeal. Management options focus on definitive radiation therapy, with or without concurrent chemotherapy, targeting the involved neck and the most likely mucosal site. I favor a selective, targeted approach covering the ipsilateral oropharyngeal mucosa and the involved neck levels, specifically levels 2, 3, and 4, plus the retropharyngeal nodes to maximize cure while minimizing late toxicity to the contralateral parotid and pharyngeal constrictors. Chemotherapy with cisplatin is indicated given the N2A nodal stage.
That is just a perfect, punchy, and defensible opening. You immediately confirmed the workup, you stated the presumed biology, you articulated the volume philosophy, and you justified the chemo.
You've covered the whole problem.
The entire scope in 1 minute. So now, let's spend the next half hour or so digging into all the details that support that rationale.
Let's do it.
So you mentioned that your first move in any unknown primary board case is to verify that the workup is complete. We really cannot overstate this.
No, you can't. If the premise is faulty, your entire treatment plan is going to be wrong.
Right.
I mean, unknown primary is the most rigorous diagnosis of exclusion we have in head and neck oncology. If the referral just says, the CT was negative, that's a massive red flag.
Huge red flag. You're about to commit a patient to weeks of high-dose radiation.
which carries, substantial long-term morbidity. We have to be absolutely certain we haven't missed a macroscopic primary that could completely change the staging, the prognosis, and of course the field size.
Okay, so let's just lay them out. The 7 mandated workup steps. This is the non-negotiable checklist you need before you can confidently apply that unknown primary label.
Okay, step 1. Complete head and neck exam plus a flexible scope. That's basic. You need to visualize the mucosal surfaces.
Right. 2 is contrast cross-sectional imaging. So a CT and/or an MRI. You need those high-res images to map the neck and look for any subtle mucosal enhancement.
3, the PET CT. This is absolutely vital. It's not just for distant staging, ruling out Mets. It's also for occult primary detection.
Right. Sometimes a tiny FDG-avid primary just lights up in the tonsil or tongue base, even when it's totally invisible on the CT.
Exactly. 4, tissue diagnosis from the node, FNA, or a core biopsy. You have to confirm it's SCC and rule out other things.
Like lymphoma, metastatic thyroid cancer, yeah.
5, biomarkers. This is the modern game changer. You must have P16 and EVV testing. These molecular markers are your new map, which we'll get into.
Okay. 6, examination under anesthesia, the EUA, with directed biopsies. This means a surgeon is in there, looking at those hard-to-see areas, deep follicula, piriform apices.
Post-cricoid region.
Post-cricoid region, yeah. With the patient asleep so they can get a great look and biopsy anything suspicious.
And that brings us to step 7. And this is the one that is so often the missing piece that creates a true unknown.
The definitive sampling.
Yes. Palatine tonsillectomy and adequate tongue-based mucosectomy or sampling. Why is this step so non-negotiable, especially in a case like this where you suspect P16?
Well, it's all about the biology of HPV-associated cancer. These primaries, they often start deep inside the tonsillar crypts or, nestled in the lymphatic tissue of the tongue base.
That can be microscopic.
They can be a few millimeters and still shed metastatic cells. So a simple superficial biopsy, that's just not going to cut it. It's like scratching the paint. You need the surgical removal of the entire at-risk tissue, the tonsillectomy, or a deep, definitive excision of the tongue-based mucosa to really exclude that microscopic primary.
I like that analogy. So if you think of the workup as searching for a key in a dark room, the CT is your flashlight, the PET CT is like a metal detector, and the EUA is physically flipping over the furniture.
Right.
But for an HPV primary, the key isn't just on the floor, it's welded inside a microsafe hidden behind a wall.
And the only way to prove that safe is really empty is to take the entire wall down.
Yeah.
That's your tonsillectomy and deep tongue-based sampling.
Exactly. So if that surgical step hasn't been done and you just accept the diagnosis, you've walked right into the first major board trap.
You haven't earned the right to call it unknown primary. Your whole plan for a selective field is now built on just a shaky foundation. You have to challenge that premise.
Yeah, your response in that situation has to be, before I definitively plan the radiation fields, I would confirm that the patient has received definitive sampling of the high-risk oropharyngeal sites.
Namely the tonsils and tongue base.
To truly exclude a primary tumor in the most likely location. Perfect.
So once that workup is truly complete, we can shift from pure anatomy to molecular biology. This is where modern management really takes a different path from the classic approach.
Yeah, instead of just guessing where the primary might be, we let the biology point the flashlight for us.
So in the absence of an anatomical target, the pathologist report, that becomes your map.
It does. And we should focus on the huge differences between the 3 major biomarker scenarios. I think of it as the biomarker risk ladder because these findings radically change your treatment field and, critically, the prognosis.
Okay, let's start with our anchor case. P16 positive and EBV negative. This is by far the most common scenario we see today.
It is. It's something like 70 to 80% of unknown primaries now, all thanks to the HPV epidemic.
So what's the takeaway here?
The takeaway is definitive. You presume an oropharyngeal origin, palatine tonsil or base of the tongue. This strong presumption is what gives you the confidence for highly selective treatment.
And the prognosis is comparatively excellent.
It is. We know from AJCC 8th edition that HPV-positive oropharyngeal disease has a dramatically better survival curve than P16 negative disease. So when you see this profile, you basically open the HPV oropharynx chapter of the textbook.
And that superior prognosis, plus the high probability that the tiny primary was actually removed during the workup.
Right, during the tonsillectomy.
That's exactly what justifies the toxicity-reducing selective treatment plan we talked about in the opening.
Okay, so moving up that risk ladder to the second rung. EBV positive. Now, even if P16 is positive or negative, if you see EBV positivity in that nodal SCC, the entire management pivots.
It pivots entirely to the nasopharynx. So why does EBV positivity automatically override everything else, even a negative scope of the nasopharynx?
Because EBV is the essential etiologic agent for most nasopharyngeal cancer, or NPC.
Right.
And NPC is famous for this exact presentation, metastatic neck nodes, while the primary mass is still small, endophytic, and just hidden up in the vault of the nasopharynx, completely missed on initial imaging or scope.
So you have to treat it as NPC until proven otherwise.
You must, and that NPC assumption has immediate, non-negotiable anatomical implications for you as the radiation oncologist.
It demands two things, right?
Two things. First, your mucosal target volume must include the entire nasopharynx, regardless of whether you see anything. And second, and this is trap number 2, your nodal volume must include the retropharyngeal nodes, or RPNS.
Because the RPNS are the first echelon drainage site for the nasopharynx.
They are, and if you miss them, you risk a very high rate of recurrence in that critical area right behind the throat. Ignoring the RPNs when EBV is positive is a classic board failure.
Okay, so finally, the most challenging scenario, the real diagnostic conundrum. P16 negative and EBV negative. This is the original true unknown.
This is what I call the failure of molecular mapping. The prognosis here is generally worse. It follows the trajectory of high-risk non-HPV SCC.
And the differential diagnosis just explodes.
It broadens significantly. Now you're thinking about the hypopharynx, the larynx, maybe less common oral cavity sites, and critically, you have to start thinking about a cutaneous source, a skin cancer.
I remember this being the most unsettling type of CUP. When the biology doesn't localize for you, you lose all the confidence you had to use a selective, toxicity-sparing approach.
You do. This requires a much broader field. And because you've lost that strong link to the oropharynx, this is the scenario where comprehensive mucosal irradiation, the historical big field, often becomes the necessary default strategy. You have to cover all those higher risk, lower mucosal sites.
So the bottom line here is that the biomarker report isn't just a prognostic tool, it's an anatomical instruction manual.
That's a great way to put it. It tells you whether you open the HPV oropharynx chapter, the NPC chapter, or the high-risk comprehensive unknown chapter.
And we should probably just briefly note that if the tissue comes back as non-squamous, let's say it's a salivary gland tumor, or thyroid cancer, or lymphoma,
then this whole head and neck mucosal paradigm just goes out the window. You pivot completely to the specific management pathway for that histology.
Right. Okay, so that brings us to the volume controversy. Comprehensive versus selective. This is the true centerpiece of the discussion.
And it's the highest yield board topic for sure. It forces you to articulate a risk calculation that balances cure, quality of life, and treatment morbidity.
We're basically fighting this essential tension. How much toxicity are we willing to trade for a tiny theoretical chance of missing a microscopic tumor somewhere else?
And in the P16 positive era, that tension is really acute because the prognosis is so good.
Okay, let's really explore philosophy 1. Comprehensive mucosal irradiation. This was the default for decades, right? Based on the idea that the primary could be anywhere in that shared mucosal corridor.
The goal was maximum disease control. You treat the neck, plus the entire major at-risk mucosal axis, bilateral nasopharynx, bilateral oropharynx, hypopharynx, maybe even the larynx inlet, depending on the nodal location.
The pros are obvious. You have a near-zero risk of a primary tumor popping up outside your field later on.
Right.
But the cons are substantial, especially today when we're treating HPV patients who have a potentially very long survival ahead of them.
The cons are high, predictable, late toxicity. When you treat that huge volume, you inevitably blast the non-involved side.
You're guaranteeing a high dose to the contralateral parotid gland,
which leads to long-term xerostomia, or dry mouth. And you're also radiating a huge portion of the pharyngeal constrictor muscles and the supraglottic larynx, which increases the risk of chronic aspiration and dysphagia, swallowing dysfunction.
These are life-altering, irreversible toxicities.
They are. And for our 55-year-old P16 positive patient, this approach often just constitutes overtreatment.
So now let's contrast that with the modern approach, philosophy 2, targeted or selective volumes. This is becoming the default for favorable biology and limited nodal disease.
The goal here is de-escalation, and it's driven by that strong biological localization we talked about. So for our anchor case, we treat the ipsilateral neck levels 2, 3, 4, the RPNS, and only the ipsilateral oropharyngeal mucosa.
The area where the primary is presumed to have been.
Exactly. And we deliberately spare the contralateral parotid and larynx.
The pros of going selective are just huge in the quality of life discussion.
The core benefit is functional preservation. By sparing that contralateral parotid, you often maintain adequate salivary function. By limiting the pharyngeal constrictor dose, you preserve the swallowing mechanism.
And this is supported by data from the HPV de-escalation trials, right?
It is. While those trials focused on known primaries, they really underpin the idea that less treatment volume in this favorable biological subset often doesn't compromise control.
But we have to be honest about the trade-off. What is the risk we are accepting when we choose the selective approach?
We accept a small but real risk of a few things. First, a true unknown primary could emerge in the untreated contralateral mucosa. Second, you could get a recurrence in the untreated contralateral neck.
Or third, the primary was actually somewhere else entirely, like the hypopharynx.
Right. But when the workup is complete and the biology is favorable, P16 positive, EBV negative large-scale retrospective data suggests that risk of missing a primary in the contralateral mucosa is extremely low, maybe less than 2%.
I think that's the key point.
Yeah.
The board examiner wants to hear that you understand that a risk is being taken,
Yes.
but that it's a calculated, patient-centered risk.
It is, and the conversation on boards should be framed around that long-term data. You have to be able to articulate that the control benefit you gain by treating the contralateral neck or the whole mucosa is minimal.
But the toxicity harm, the xerostomia and dysphagia is high and predictable.
Exactly. We're prioritizing quality of life over a very low probability event.
Okay, let's introduce a point of clinical conflict here. Isn't it true that in a lot of centers, even with a single level 2A node, they might default to bilateral elective neck coverage? Why is that?
That practice often comes from, institutional habit, or maybe it's a borderline case. The node was a little medialized, raising concern for a base of tongue source that could cross the midline.
Or just psychological reasons.
Or that, yeah. A patient finds a recurrence in a contralateral neck that was intentionally omitted. That's emotionally devastating. But for a truly lateralized, limited level 2A node in a P16 positive patient, the contemporary evidence-based direction is to argue for ipsilateral neck treatment only.
And if you do opt for bilateral coverage,
you have to constrain the dose aggressively on that contralateral side to protect the parotid and the pharyngeal constrictors. You're usually trying to keep the dose below 45 gray to those critical organs.
So the correct board response isn't a single universal answer. It's a rationale.
It's a rationale. You choose targeted volumes to reduce predictable long-term toxicity, accepting a small, low risk of late emergence, given the complete workup and the favorable HPV biology.
All right, let's pivot to the actual technical execution. This part often gets neglected in the big philosophical debate.
When you're planning an unknown primary case, you're managing both a mucosal risk and a definitive nodal disease.
So we need to review the two main neck management pathways. You'd have to think beyond just the primary site.
Okay, so pathway 1 is definitive radiation or cum radiation. This is the path we chose in our anchor case. It's used for bulky nodes, fixed nodes, or if the patient is just not a good surgical candidate.
The gross disease gets the highest dose. Elective neck gets covered based on the presumed drainage.
Right. Then there's pathway 2, neck dissection first. This is a great alternative for selected limited nodal disease, like an N1 or a small N2A.
And the benefit there is superior pathology.
It is. The surgeon gives you a clear picture of how many nodes are positive, and crucially, whether there is extranodal extension or ENE.
ENE. That's such a key surgical risk factor. It means the cancer has grown outside the lymph node capsule.
It is. And if ENE or positive margins are found after the neck dissection, then adjuvant postoperative radiation is mandatory and concurrent chemotherapy is required.
And that's based on those seminal trials, RTOG 9501 and EORTC 22931.
Absolutely. They showed adding cisplatin in that high-risk setting dramatically improved survival and regional control.
Okay, so that brings up a critical response assessment pearl for pathway 1. If we treat that 3-centimeter level 2A node definitively with chemoradiation, how do we confirm it's gone?
You get a PET-CT for response assessment at about 12 weeks post-treatment. If the PET shows a complete metabolic response in that node, we typically just observe.
And if it doesn't? If there's still FDG uptake?
That patient requires a planned salvage neck dissection because there's a high likelihood of residual viable disease.
Okay, let's apply this back to our anchor case. Right, level 2A, 3-centimeter node, P16 positive. We chose the targeted strategy with definitive chemoradiation. Can you detail the conceptual target volumes and the contouring nuances you'd need to verbalize?
Sure. The mucosal volume is oropharynx focused. This would include the tonsillar beds, the soft palate, lateral pharyngeal walls, and the entire base of the tongue region. And that's all treated to an intermediate dose.
And the board nuance here is laterality. Ipsilateral versus bilateral oropharynx coverage.
Right. Since our case is unilateral and P16 positive, the most common modern approach is to treat the ipsilateral oropharynx to that intermediate dose level, say 60 gray, and spare the contralateral side almost completely.
You're really focusing on limiting the contralateral parotid dose.
Yes, usually a mean dose less than 26 gray, and also the contralateral constrictors. Now, if the nodal disease had been N3, or if that node was right in the center, then you'd be forced to treat the oropharynx bilaterally.
Okay. Now for the neck coverage. Which levels are mandatory?
Mandatory coverage includes the involved side, levels 2, 3, and 4. We typically cover these to a high elective dose, and we also must include the retropharyngeal nodes.
The RPNS, why?
Because of the presumed oropharynx biology, which very often drains to the RPNS.
Let's get technical on contouring the RPNs. Where do you start and stop, and what's the rationale?
This is where precision really matters. The RPN PTV has to extend superiorly all the way to the skull base, specifically the roof of the nasopharynx, to cover the entire superior extent of the fossa of Rosenmuller.
Which is the high-risk zone.
It's the highest risk zone for nasopharyngeal primaries. And inferiorly, the coverage extends down to the level of the C2 or C3 vertebral body, covering that chain. If you truncate that superiorly, you risk missing a high recurrence near the skull base.
And what about the contralateral neck levels?
For a low-risk, unilateral level 2A P16 positive case like this one, omission of the contralateral levels 2 through 5 is acceptable and honestly often preferred to reduce toxicity.
It's a deliberate de-escalation.
It's a reasoned de-escalation. Now, if the patient had bilateral nodes or a high-risk midline primary, then we would treat the contralateral levels 2, 3, and 4 electively, probably to 50 or 54 gray, while still being super aggressive on our contralateral parotid constraints.
Let's cement the dose and fractionation scheme. Talk about the 3 dose levels you'd use in a simultaneous integrated boost or SIB-IMRT plan.
Sure, we'd use 3 dose levels. 1, the gross disease dose, or PTV-GTV. The 3-centimeter node gets the definitive dose, typically 66 to 70 gray.
In 33 to 35 fractions.
Right. 2, the high-risk elective dose, PTV-1. This is the suspected primary bed, the ipsilateral oropharynx, and the immediately adjacent nodal regions. They get an intermediate high dose, maybe 60 to 63 gray.
And finally, the low-risk elective.
That's PTV2. The remainder of the elective neck, levels 3, 4, and the RPNS, they get the standard elective dose, which is usually 50 to 54 gray.
And that really demonstrates a mastery of IMRT planning, creating those nested target volumes to modulate the dose based on microscopic risk.
Finally, on chemo, let's just reiterate. When is concurrent cisplatin mandatory for CUP?
It's mandatory when the patient has standard high-risk features for systemic failure or locoregional control. So N2 or N3 nodal stage, bulky disease, usually over 3 centimeters, or any suspicion of ENE.
So for our N2A case with a 3-centimeter node.
The risk is high enough that concurrent cisplatin, usually every 3 weeks, is the standard of care. It's the nodal burden, not the lack of a primary, that determines the need for systemic therapy.
We've built a successful plan. Now let's talk about the pitfalls.
The traps. These are the 3 common mistakes that cause residents to just stumble on boards and can often lead to a failed section.
Okay, let's call them the 3 major oral board traps. Trap 1 focuses entirely on the definition of the disease itself. Trap 1 is workup completeness. The mistake is just committing to a treatment plan when the workup is insufficient. If the case writer says the patient had a negative CT and just a superficial tongue-based biopsy, you cannot proceed with a selective plan.
You have to identify that the palatine tonsillectomy and adequate tongue-based sampling are missing.
Right.
Your first move is to challenge the premise. You have to tell the examiner that you would mandate completion of the workup first, because if the primary is later found in the tonsil, you've avoided a huge mistake.
Trap 2. Missing the biology, I call this the EBV error. This is the failure to mandate nasopharynx and retropharyngeal coverage when EBV is positive.
We said it before, but EBV positivity is nasopharyngeal cancer until proven otherwise.
It is. It's an immediate requirement to treat the entire nasopharynx mucosal volume and anatomically include that RPN-PTV all the way up to the skull base. Ignoring that is an immediate fail in the head and neck section.
Okay, and trap 3.
Trap 3 is misapplying P16 logic. This is the mistake of using a selective HPV-driven oropharynx-only plan when the biology just doesn't support it, meaning P16 is negative and EBV is negative.
Right. When P16 is negative, that strong link to the oropharynx is gone. The differential is wide open again. Hypopharynx, larynx, skin.
So in this true unknown scenario, using a selective plan accepts way too much risk of emergence outside your field. The default strategy has to revert to a more comprehensive mucosal approach to cover that broader differential.
And you have to have a vigilant skin check if the nodes are in the upper levels or the parotid basin.
Absolutely. So to help synthesize all this, let's use a mnemonic for a truly defensible unknown primary plan, CBVT.
CBT. I like it. Let's break it down.
C is for complete workup. Did they get the tonsillectomy and the adequate tongue base sampling?
B is for biomarker map. What are P16 and EBV telling you about the presumed site? Oropharynx or nasopharynx?
V is for volume selection. Choosing that risk-adapted approach, comprehensive versus selective.
And T is for toxicity rationale. Verbalizing the functional trade-off, like salivary and swallow preservation, that justifies the volume you chose.
Master the CBVT framework, and you're going to master the unknown primary board section.
Excellent. Let's move into our rapid recall drill, just to solidify these high-yield facts. Quick facts only.
I'm ready for the blitz.
The most likely primary site for P16 positive, EBV negative CUP.
Oropharynx, palatine tonsil, or base of tongue.
What specific dose constraint is the primary motivation for favoring a selective unilateral treatment plan?
Dose limitation to the contralateral parotid gland and the pharyngeal constrictors to minimize xerostomia and dysphagia.
Name the specific surgical finding that mandates concurrent cisplatin in the adjuvant setting after a neck dissection.
Extranodal extension, or ENE.
What's the current trend for P16 positive unilateral limited nodes after a complete workup?
Selective oropharynx-directed strategy to minimize long-term functional toxicity.
The dose range, in gray, typically given to elective nodal regions like level 4.
50 to 54 gray.
Fantastic. Now let's flip it. I'll be the resident. You challenge me with some rapid-fire board bliss questions.
All right, question 1. A 60-year-old patient presents with SCC in a level 2 node. Case summary says P16 negative and EBV negative. Workup is complete, including definitive surgical sampling. What is the most appropriate radiation volume philosophy? A, ipsilateral neck only. B, ipsilateral oropharynx plus ipsilateral neck only. C, comprehensive mucosal irradiation plus neck. Or D, nasopharynx plus neck only.
The most defensible answer there is C, comprehensive mucosal irradiation plus neck. My rationale is that with no localizing biomarker P16 negative, EBV negative, the risk differential is wide. The primary could be in the hypopharynx or larynx. So relying on a selective plan risks a high morbidity emergence in an untreated site, which forces us back to the classic, broader field approach to cover the entire at-risk mucosal axis.
That is correct. Question 2. An EBV positive node presents high in the neck. No visible primary is seen on MRI or scope. If you choose a definitive chemoradiation approach, which elective nodal region is absolutely critical to include in the PTV, and what is its superior boundary?
Okay, the critical elective region is B, the retropharyngeal nodes. The EBV status dictates we treat this like NPC. The superior boundary for RPN coverage must extend all the way to the skull base, specifically, covering the jugular foramen region and the superior aspect of the nasopharynx vault, because NPC is famous for superior extension and high RPN involvement.
Excellent. Final question. A 35-year-old P16 positive unknown primary with a single unilateral level 2 node is treated with a highly selective strategy, ipsilateral oropharynx and ipsilateral neck only. 2 years later, the patient develops a new, small, contralateral level 2 node recurrence. This is most consistent with A, failure of biomarker logic, B, a failure of systemic therapy, C, a known accepted trade-off of selective volume omission, or D, proof that bilateral mucosal radiation therapy is mandatory.
The answer is C, a known accepted trade-off of selective volume omission. My rationale. By choosing a unilateral strategy for this very low-risk, highly curated patient population, we accept that there is a small, low single-digit risk of a contralateral neck failure or mucosal emergence. We accept that risk because the alternative guaranteeing high long-term dysphagia and xerostomia by treating the healthy side is deemed a greater harm to the patient's long-term quality of life, especially in a young HPV patient. It's a calculated risk management decision. Perfect. That brings us to the end. Let's just distill everything we talked about into 4 high-yield clinical pearls. Okay, I'll add the essential context for each one. Pearl 1. Unknown primary is a diagnosis of exclusion. If the workup isn't complete, the diagnosis isn't real.
Meaning, you have to verify the 7 mandated steps, especially that definitive surgical sampling of the tonsils and tongue base. If you don't have that, you stop. You address the workup first.
Pearl 2. P. 16 points to oropharynx. EBV points to nasopharynx. Let biomarkers choose the chapter and the volume.
Biology is your map. It provides the anatomical rationale that lets us safely de-escalate treatment volumes in favorable cases, but it also demands aggressive, mandatory coverage of the RPNS in EBV-positive cases.
Pearl 3. Volume controversy is the test. Comprehensive reduces emergence, but increases long-term dysphagia and xerostomia. Selective reduces toxicity, but accepts a small, calculated miss risk.
The board discussion is always about that trade-off. Your choice reflects your clinical rationale. For low-risk HPV cases, the risk of unnecessary toxicity outweighs the low risk of recurrence in the untreated corridor.
And Pearl 4. If it's P16 negative and EBV negative, think broader, and don't forget skin.
That failure of the molecular map means selective volumes are often just inappropriate. You must widen your differential and your field to cover the higher-risk lower mucosal sites, and always ensure a thorough evaluation for a cutaneous primary if the node distribution allows for it.
So to recap everything, unknown primary demands a rigorous diagnostic checklist. Biomarkers are the modern tool we use to localize the likely primary site, and the ultimate clinical decision is volume selection, an intentionally risk-adapted choice between toxicity and emergence, guided by biology, nodal burden, and workup completeness, all using precise IMRT, planning to spare organs at risk.
That comprehensive review should put any resident in a really solid position to tackle the unknown primary scenario on oral boards.
Next time we'll transition to the next topic, AJCC 8th edition staging, including how P16 status changes everything.
Get ready for that. That's another essential board topic. Complete practice oral boards at radonsmartlearn.com and subscribe to Rad Onc Smart Review for our next episode. Thanks for tuning in.